Our next presenter is Dr. Toni Zhong, is a plastic and reconstruction surgeon at the Toronto General Hospital. She served as Belinda Sternon's chair in breast cancer reconstruction at University Health Center. She's a clinical lead of the breast reconstruction working group at Cancer Care Ontario, and she led the development of the clinical guidelines for breast reconstruction patients in Ontario. Her presentation is titled Breast Reconstruction Using Implants. Please join me in welcome Dr. Toni Zhong.
Thank you to the organizers of this event. And Laura Lynn, I think your story was just so powerful but uplifting. Tonight, I'm honored to speak about breast reconstruction using implants. So we know that in both Canada and in the United States, reconstruction using implants is the most frequent type of breast reconstruction. We also know from this study that we did in Ontario that using implants is also the fastest growing type of reconstruction, while using your own tissue remains relatively constant. So why this increase in the use of implants? Well, surely celebrities and influencers talking about their breast cancer journey using implants has helped to destigmatize talking about breast reconstruction. But also important are these 4 factors that I've listed here, and we'll go into each one of these factors in more detail. So first of all, I think attitude towards reconstruction is changing. So my patients told me this. I had reconstruction, not out of vanity. It's just a matter of being able to wear what I want to wear and feel comfortable with what I am wearing. Another patient told me, I could never wear a swimsuit or that sort of thing. Most of my clothing was just off limits, even with the padding and stuff, because bras, it just doesn't look right. So not only are the attitudes of women undergoing reconstruction changing, but so are the attitudes of those of us performing breast reconstruction. This study surveyed female plastic surgeons who perform reconstruction, and this study found that 66% of female plastic surgeons chose implants as their #1 type of reconstruction, and they cited non-invasiveness and easier recovery as the #1 reason. Also, we know that patients who are undergoing mastectomy today are younger. Not only is genetic testing now more widely used, but the age for breast cancer screening is lowering. But also, unfortunately, we do know that breast cancer is being diagnosed in younger and younger women. But I also think that the third driving factor towards implant reconstruction is that we have now a wider selection and safer implants on the market. In the United States, FDA requires regulatory surveillance of silicone implants. And this has really helped to alleviate some of the safety concerns around implants. So the fourth factor driving the increased use of implant reconstruction is that we have improved surgical approaches to mastectomy with immediate implant reconstruction. The 2 most commonly used surgical approaches are the skin-sparing mastectomy and nipple-sparing mastectomy. In a skin-sparing mastectomy, a limited incision is drawn around the nipple areolar complex so that it is removed. So a patient would look like this after skin-sparing mastectomy and implant reconstruction. In a nipple-sparing mastectomy, an incision is designed somewhere on the breast where the nipple areola is spared. my preferred approach is the inframammary fold approach or the lateral mammary fold approach so that the incision can be hidden in a more concealed area of the breast. So this is a post-op patient who has had bilateral nipple-sparing mastectomy with implant reconstruction. Another surgical innovation is that we're now able to provide direct to implant reconstruction as opposed to the traditional two-staged tissue expander implant reconstruction. This is not possible in all patients, but it is a good option in patients with smaller breasts or medium-sized breasts who don't want a lot of change to their breast volume or their breast shape. And this has been made possible because of the development of acellular dermal matrix, which is basically a new biologic material, and the use of intraoperative SPY angiography, which allows us to evaluate how good the mastectomy skin is and the quality of blood supply. Also, acellular dermal matrix and SPY technology have given us the ability to be able to put the implants in some patients above their muscle rather than under the muscle. Again, it is not possible in all patients, but in some patients who prefer not to have their pectoralis major muscle disturbed or bodybuilders, this is a good option. I also think that one major advancement that we've made in implant reconstruction is that we can do this better now in large-breasted patients. We know that in the past, large-breasted patients have not been entirely satisfied with the aesthetic outcome of their implant reconstruction. They often feel that their reconstructed breasts look flat, and they talk about this pancake appearance. But as plastic surgeons, we do a lot of breast reductions, and I think we use a variety of different incisions for these breast reductions that can help our breast surgeons with designing incisions for these large-breasted women. So at the same time, they can have a skin-reducing mastectomy, and we can provide implant reconstruction. So this is a patient before and after that. And in some patients who are large-breasted, who are gene positive and are thinking about undergoing preventative or prophylactic mastectomy with implant reconstruction, they can also be candidates for a staged approach. So in the first stage, they can actually have a bilateral breast reduction or lift to make their breasts more even. And then at the second stage, then they can have the definitive mastectomy, nipple sparing with implant reconstruction. So this is a patient of mine who's BRCA1 positive, and you can see she has existing asymmetry in her nipples. And after her mastectomy, she wanted her nipples to be more even, and she wanted her breasts to be smaller. So this is exactly what we did. In the first stage, we gave her bilateral breast reduction to make the nipples more even and at more aesthetic location, and her breasts smaller. And then the picture on the right is her 12 months after undergoing bilateral nipple-sparing mastectomy with direct to implant. So in conclusion, is implant reconstruction the next best thing? No, it is not. It is not everyone's number one choice, and it is not the preferred choice in every patient. But in my practice, my patients who have undergone reconstruction, whether it's using implants or their own tissue, have told me that the benefits can be life-changing. Thank you.